Well, again, thank you all so much for joining. This is really supposed to be a participatory sort of meeting where we'll have a quick didactic and then present some interesting cases. In the future, again, any case that any of our participating facilities or anybody throughout the state of New Mexico, if you have concerns or questions regarding emergency care, whether it be trauma or medical, those are the kind of cases we want to present and have open for discussion. So without further ado, I'd like to introduce Lauren Thorpe. Dr. Thorpe is one of our senior fellows in pediatric emergency medicine at the University of New Mexico. She was really the person who brought multisystem inflammatory syndrome to children to me, when we started thinking about things way back in February and March of this past year. And so I felt it only appropriate for she be the one to do our inaugural presentation. Thanks, Lauren.
Hi, everyone. Thank you so much for this opportunity. I'm going to give a quick overview on multisystem inflammatory syndrome in children today. Can everybody hear me okay? See the slides? Great. Okay, so we can go to the next slide, please.
Dr. Bullard-Barrett, we do have just a disclosure slide real quick that just says we really don't have any disclosures.
Right, none of us are making any money. What can we do? But this Child Ready is funded through a HRSA grant, just for full disclosure.
Okay, so I'm going to touch on a little bit about the background of MISC, talk about clinical presentation, go over some case definitions, and then our workup and treatment. Next slide, please. So MISC was first recognized in the United Kingdom a year ago in April of 2020. At a large hospital there, providers noticed a cluster of 8 children in a 10-day period with this hyperinflammatory shock and evidence of severe acute respiratory syndrome coronavirus 2. So these kids were really sick. They were presenting with high fever, elevated inflammatory markers. Many of them required pressors and required mechanical ventilation. So this cluster was the basis of a national alert and was published in early May. And then on May 1st, the Royal College of Pediatrics and Child Health put out a case definition on this syndrome and also guidance. They called it pediatric inflammatory multisystem syndrome. And then on May 4th, New York State started noticing children with this inflammatory syndrome as well and put out a health alert and recommended that providers start reporting these cases. And then in Italy on May 13th, a paper came out kind of describing the incidence and features of this new, they called it a Kawasaki-like illness. And they compared these patients during the pandemic to Kawasaki disease patients before the pandemic. And what they were noticing was that this new inflammatory entity was much more severe than typical Kawasaki. Many more of the patients were having shock, abnormal echocardiograms, and requiring more adjunctive treatments. And then on May 14th and 15th, the CDC and WHO came out with case definitions for multisystem inflammatory syndrome. And then over the next few months, a series of papers were published describing patients with this new emerging entity called MISC. And I think we have a couple arrows, and then the next slide, please. Thank you. So pediatric patients we know are susceptible to severe acute respiratory syndrome coronavirus 2 that causes COVID-19, but develop symptomatic COVID-19 and severe disease at a lesser rate than adults. But however, some of these children are getting this life-threatening hyperinflammatory syndrome. The CDC has reported a total of 3,185 cases so far in the United States and 36 deaths. And a report from New York State looking at a couple months last spring estimated the incidence of MISC to be 2 per 100,000. So the pathogenesis is not well understood. It's thought to be a post-infectious complication occurring about 2 to 4 weeks after peak incidence of COVID-19 in communities and involves some sort of immune dysregulation. And so most of these MIS-C patients are having serology showing prior COVID infection. So that is supporting this thought. And then patients are also responding well to immunomodulation, also supporting this thought. Next slide, please. Okay, so what is MIS-C looking like? Typically, it's manifested with fever in all patients. We're seeing 4 to 6 days of high fever. Some of the other big things we're seeing are gastrointestinal symptoms, abdominal pain, vomiting, diarrhea. Patients are also having colitis, hepatitis, and symptoms even mimicking acute appendicitis. Where a lot of the patients are having conjunctivitis up to 50%, and rash in about 56%. We're seeing frequent cardiovascular involvement, shock, and hypotension. And then we can also see some respiratory and neurological involvement, as you can see here on this table, but at lower rates. I think we're ready for the next slide. A couple clicks and then next slide, please. So this chart on the right is from a systematic review looking at mean lab values of about 662 patients with MIS-C. The typical lab findings we're seeing in MIS-C are elevated inflammatory markers, elevated CRP, ESR, D-dimer, ferritin, procalcitonin. There's a very long list. Hypoalbuminemia, hyponatremia. We're also seeing abnormal blood cell counts, neutrophilia, lymphopenia, mild anemia, and thrombocytopenia. And then, of course, we're seeing elevated cardiac markers, so bumps in troponin and BNP. We can also see elevated liver function tests, and we're seeing acute kidney injury in about 18% of these patients. Next slide, please. And so this table is from the CDC Morbidity and Mortality Weekly Report looking at 570 patients with MIS-C. And as you can see, cardiovascular involvement is a big deal with MIS-C. We're seeing this in about 86% of patients, some sort of cardiovascular involvement. The big ones being shock in 35%, elevated BNP, cardiac dysfunction in 40%, and hypotension in about 50% of patients, which is huge. We're also seeing myocarditis, coronary artery abnormalities, and pericardial effusion. Next slide, please. And then this table is from a JAMA article looking at around 500 patients with MIS-C as well. And kind of going over the clinical course here, you can see that about 56% are requiring some sort of respiratory support, 17% in this article required mechanical ventilation, and then about 74% required ICU level of care. Right, a couple of clicks and then the next slide, please. Thank you. So there is the diagnosis of Kawasaki disease requires similar clinical findings and laboratory criteria, and there is some overlap in about 40 to 50% of patients meeting MIS-C criteria. They're also meeting criteria for complete or incomplete Kawasaki disease. So what are some of the big differences that we're seeing? So most children with MIS-C are older, ranging from 8 to 9 years old versus that 3-year-old age in Kawasaki disease. We're also seeing Black and Hispanic children being disproportionately affected by MIS-C and obesity as a possible underlying condition in MIS-C. We're also seeing more frequent, and just a click whenever you're ready, please, more frequent GI symptoms and higher frequency of cardiovascular involvement and shock in MIS-C. And so the shock is much higher in MIS-C. Kawasaki disease typically has a rate of shock of 5% or less. And then next slide, please. So there's multiple case definitions going on with MIS-C. We're going to kind of focus on the CDC case definition, and that is patients under 21, fever of at least 38 Celsius for at least 24 hours, or subjective fever for that amount of time, and then laboratory evidence of inflammations, some of those markers we talked about earlier. And then evidence of severe illness requiring hospitalization involving at least 2 organ systems. No alternative diagnosis, and then positive for current or recent COVID infection or exposure history. Next slide, please. And this chart just compares some of the different definitions, the Royal College of Pediatrics Child Health, CDC, and WHO. We're kind of focusing on the CDC definition here in the United States, but some of the big differences are age, length of fever, and then PCR serology testing. Okay, next slide, please. So this is our UNM Hospital MISC testing guideline, which was developed by the wonderful Dr. Duran, Dr. Jolly, Dr. Muller, and Dr. Turi. I know it's hard to project on one PowerPoint slide, but it's very helpful. So I just wanted to go through it just a little bit. So our big question is, when should we be considering a diagnosis of MISC and getting labs for these patients? And so we're really wanting to consider this in sick patients that have had 3 days of fever. We're not seeing another clear source of infection, and we're seeing signs of organ dysfunction. It can be helpful if they've had a recent COVID-19 exposure or infection, but we may not always get that history. And also, if the kids are looking like they have Kawasaki disease, regardless of how long the fever has been going on, we want to go ahead and get that MISC workup going. So if we kind of look at this chart, if we're seeing a ill patient with 3 days of fever, it's a little more straightforward if they're looking septic and we're going over to the right and going down the sepsis pathway. If we're on those initial sepsis labs, which are similar to our MISC screening labs, if we're getting an elevated CRP, ESR, and then one of the following, lymphopenia, platelet abnormality, elevated neutrophil count, low sodium, elevated creatinine, low albumin, then we're going to go ahead and get the expanded MISC labs and get the patient admitted, get our consultants involved, and report the case. It's a little more tricky when the patients aren't quite as sick and we're going down kind of the left side of the algorithm. If we're not having a concern for sepsis when they look ill and have had fever for 3 days, we're doing our regular ED workup for them. Are we seeing clinical features of MISC, which can be pretty easy to meet, as you can see, because of how many systems can be involved. So if we are seeing those features, we're going to want to go ahead and get the screening labs, the CBC, CRP, ESR, Chem10, and LFTs. And then again, on the right, if we're seeing those abnormalities, we're going to get the expanded MISC labs. If not, we're going to go back to the left, and if we're not seeing another source of symptom of fever like UTI, scarlet fever, then we're going to want to have them and they're looking well enough to go home, we're going to want to have close follow-up in 24 hours. Okay, next slide, please. And so this again it's a 2-tiered guideline. So these are our screening labs, some CBC, chemistry, inflammatory markers, LFT, and urine, and the lactate. And then next slide, please. And so there's multiple subtypes of MISC, which we are not going to get into today, but just know that there's a spectrum of illness severity, and some kids can have mild symptoms and some kids can be really severe and decompensate quickly. Next slide, please. So MISC treatment, we're treating shock and sepsis per standard protocol with IV fluids, pressors when necessary, broad spectrum antibiotics when they're septic. And all patients with MISC are treated with IVIG. Steroids are generally reserved for moderate to severe cases, cardiac involvement, persistent fever, or uptrending inflammatory markers. There was actually an observational study published in JAMA in March that saw that treatment with IVIG plus methylprednisolone versus IVIG alone was associated with a more favorable fever course and less severe complications like left ventricular dysfunction and hemodynamic support requirement. And then all patients with MIS-C are treated with low-dose aspirin. They're at risk for clots, so unless there are contraindications to that. And then there's additional therapies, adjunctive therapies that can also be considered after discussion with subspecialists. Okay, next slide, please. So just wanted to talk about a couple of take-home points. So we just want to consider MIS-C when we're thinking about sick children with fever, typically 3 days. And then knowing where to find the case definition and guidelines. The AAP has a really nice website with guidance, including the CDC definition, workup and treatment online. And then if these kids are looking sick, they can decompensate quickly. So we want to think about getting those expanded labs and echocardiogram and EKG early. And also getting our consultants involved early, like cardiology and infectious disease. And then these cases need to be reported to the New Mexico Department of Health. Okay, next slide. Thank you. And we'll talk questions.
Thank you so much, Lauren. That's an awful lot of material for us to try to get in 15 minutes. But I wanted to kind of help focus in for our group here, which is much more emergency medicine, community-based. For the patients that you're considering MIS-C, what's kind of the basic lab stuff that you want to do?
Those initial screening labs, the CBC diff, chemistry, LFTs, CRP, ESR, urine, and a lactate to start with.
And for those who are practicing in other sites, are pretty much all of those tests readily available through your labs? CRPs and lactates in particular?
And feel free to use the chat box if you don't want to go online.
All right. And, you know, one of the things, and I know, Lauren, this is kind of unfair because I noticed it yesterday, and, you know, perhaps Dr. Duran or someone else can weigh in on it. I noticed that included in our screening lab is MAG and FOSS, and I'm not really sure why those are there. Does anybody have any information on those two specifically?
Hi, it's Dr. Duran. I think more just from the electrolyte derangement that you can see. And again, all of these tests are really designed to help point us in a certain direction. If we see tachycardia, but no signs of dehydration or electrolyte abnormalities, we really want to think past that. We should see things kind of matching together. And when we don't see that, we do want to expand our differential to include MIS-C.
And I know that the array of labs seemed a little overwhelming, but when I started to look at them a little more, a lot of them are the standard labs for a very ill, sick presenting child. There's only a few that would be abnormal for most places, I believe.
Yeah, so I think Dr. Thorpe's take-home message of, hey, this is something that nowadays we just have to have it on our radar all the time. You know, anytime you've got a kid who's sick or a kid who doesn't make sense, which is tough when you think about how many children present with fever of 2 or 3 days, a cough and diarrhea. And do we have to be thinking about, is this MIS-C every time? And you know, I think it needs to be in the back of your head, just like in the old days, we used to talk about, if you think about doing an LP, you should do it. I'm not sure that we're quite there with MIS-C, but I think that it's something that, yeah, we're drawing more bloods on people with fevers than maybe we did a year ago. And with that, I want to introduce our next speaker, Dr. Anna Duran, who has really been one of the spearheads on taking care of our kids at UNM with MIS-C. She's an associate professor of pediatrics and the clinical vice chair of pediatrics, as well as one of our lead pediatric hospitalists. It has been my pleasure to work with her for almost 20 years now. So with no further ado, Anna's going to present a couple of really interesting cases that highlight some of the things that we just discussed.
Thank you, Jeff. I appreciate that. And yes, it's wonderful to see everybody. I've worked with so many of you for a very long time, and it's just wonderful to see you on this venue. I was part of the original MIS-C committee that helped to design all of the lab draws that we do, and there have been quite a few revisions to address some of those concerns. Additionally, we collect all of the cases that present to UNM Hospital and share these with the Department of Health. To date, we've had over 40 MIS-C workup with about 22 cases that we felt met MIS-C criteria. I'm going to present two cases today, one that is a classic MIS-C Kawasaki-like presentation and one that was not so classic. Next slide, please. And I'm also going to start by apologizing. I'm working off of my cell phone because I could not log on to Zoom on my laptop. So I cannot see a chat. So if you have questions, please interrupt me. I'm happy to address them. All right, so our first case is a 2-year-old male who presented with 4 days of fever to our pediatric emergency department. Very classic fever. However, he did have a rash that started about 4 days in addition to his fever. His rash started on his leg, spread to the rest of his extremities, and mom noticed his rash to the palms and soles. What was interesting is this rash seemed to come and go, was more pronounced with his fevers. Additionally, he had diarrhea for 4 days and what mom noted, red eyes, which we would call conjunctivitis, no eye drainage, and then mom reports he had eyelid peeling. Skin peeling. And then overall, just not feeling well for a couple of days, poor PO intake, pretty cranky, very classic what we see with our Kawasaki patient. Next slide, please. Interesting, his grandparents had tested positive for COVID approximately 4 weeks prior to our patient presenting. With his review system, everything was negative. His family history, social history is also non-contributory. And then his past medical history was, for the most part, negative. Next slide. Physical exam, heart rate, 47, temperature 36.6. So again, thinking about that tachycardia in an afebrile patient makes you think maybe a little bit more about dehydration. Respiratory rate was 34. He was sitting well on room air. We did not have blood pressure obtained, and he had an adequate weight. He was alert, interactive, and talking. His HENT was atraumatic, normal cephalic. TMs were clear. He did have noted bilateral conjunctivitis, conjunctival erythema with limbic sparing, and no drainage. His pharynx showed a little bit of erythema, no exudate, some white spots on his tongue, but he did have dry, cracked lips. The skin, he was noted to have a reticular macular rash, noted to the torso, upper extremities, palms, soles, and some desquamation of eyelids, but not to the palms or soles. Next slide. This physical exam continuing, we had some mild cervical lymphadenopathy, good range of motion. He was tachy, but did have regular rhythm with normal S1, S2, no murmurs, and did have equal pulses. His breath sounds were clear throughout, and he had no noted increased work of breathing. His abdomen was soft, non-tender, and normal GU, and his neuro exam was alert, active, and no focal deficits. Next slide, please. So for this patient with 4 days of fever, rash, conjunctivitis, diarrhea, tachycardia, course, our differential that started in our pediatric emergency department was MISC versus Kawasaki versus other viral processes, of course. Just to point out what his electrolytes looked at this time, he had a mildly elevated white count with a predominant neutrophil shift, 20% lymphocytes, some variant and some dull bodies. Normal H&H, platelets 176. And really want to look at platelets because in Kawasaki, we generally see elevated platelets. And most of our patients will have normal platelets in the MISC population. His SED rate was mildly elevated at 78 and his CRP impressively elevated at 20.9. His BNP was 2,069 with 125 being normal high. So electrolytes for the most part were within normal range. He did not show any metabolic acidosis and or acute kidney injury. Albumin low at 2.3, which you can see in Kawasaki as well as your MISC population. And the remainder of his chemistries were within normal limits and as well as his liver function test. His EKG at that time was normal and his COVID-19 test was negative. Next slide, please. So chest x-ray demonstrates a no active pulmonary process going on. He did have some mildly dilated loops of Bell, but for the most part looked very, very good.
And I
Next.
do apologize for the lateral looking like it's back from the 60s. That isn't what it really looks like, people. It was normal.
Thank you. Next case. I'm sorry, next slide, please. So,
Dr. Duran, hi, excuse me, it's Robert Sapien. Can you go back to the x-ray for a minute?
yes, sir. Prior slide, please.
And did they comment at all on the heart looks generous? Did anybody comment on that?
They did not comment on it and actually stated that he had a normal cardiac silhouette. But we do know he had a small pericardial effusion with his first echocardiograms. Any other questions?
No, thanks.
Next slide. So for hospital day one, again, with the suspicion for MISC, we had ID and cardiology consult. He had an elevated D-dimer of 4,770. His ferritin was elevated. His procalcitonin and troponin, however, were within normal limits. His echocardiogram normal with the stated pericardial effusion and no noted coronary aneurysms. As stated, his COVID-19 PCR was negative, but his COVID IgG antibody was positive. The patient received IVIG and high-dose aspirin on day one of hospitalization. Because of his elevated D-dimer, we did start Lovenox, and shortly after getting his IVIG, the patient was afebrile and actually looked like a completely new child. He was discharged on day 3 of hospitalization, transitioned to low-dose aspirin that he continued for 6 additional weeks, and had follow-up with pediatric cardiology with repeat echocardiograms at weeks 2 and 6, again showing normal echocardiograms. All right, so that is our first case that has more of a classic Kawasaki-like picture. Any questions?
Anna, could you kind of speak a little bit towards the use of the IgG as opposed to IgM? You know, I always thought that you looked at IgM in acute illnesses, and kind of does that make sense with the negative PCRs to still have the positive IgG?
Yeah, so we do know that the PCR can be positive up to 3 months, but is not a reliable source of showing active disease, if you will. We do use the antibody IgG. We know that IgM, COVID IgM and IgG rise simultaneously. However, your IgM does have a quicker decay time. It's usually gone within 2 or 3 weeks. and IgG can be there for many months after. So we use that as a more reliable source to show past infection, but not current infection.
Okay. So then with most of these cases, we really are looking in that 2 to 4 weeks post disease.
Correct, yes.
Okay.
And by definition, by CDC definition, yes.
Okay.
So Anna,
Yes.
I had a question. This is Katie. My recollection with Kawasaki's is we always talked about, along with the head and neck, conjunctivitis, the swollen lips, etc., mild cervical adenopathy or supraclavicular. And I don't think I heard you mention that, and that doesn't seem to be a part of the MISC. Is that correct?
You can see lymphadenopathy in some MISC cases. This patient did have some mild cervical lymphadenopathy. By the time I saw him, I could not appreciate that.
Okay, thank you.
Thank you for your question. Any others? Okay, let's move on to the next case. Next slide, please. So this young lady is a 2-year-old female who presented via ambulance from an outside urgent care clinic with respiratory distress. She went to bed the evening prior without any complaints and woke up the following morning with rapid breathing. She had worsening shortness of breath throughout the day and decreased PO intake. When she presented to the urgent care setting, she was noted to have a respiratory rate between 80 and 90, a heart rate of 180, and a capillary refill of 4 seconds. When EMS arrived, she was received an IV with normal saline bolus, and oxygen was initiated. Next slide, please. So the patient's past medical history only really included a visit to our pediatric emergency department approximately 3 weeks prior for diarrhea that was thought to be associated with amoxicillin, which she had been started on for otitis media. Her diarrhea resolved between that PDD presentation and today's presentation. She had no history of fever, cough, possibility of foreign body, runny nose, vomiting, or diarrhea with this current episode. Her review system was non-contributory. She had no past medical history, surgical history, meds, allergies. Her only family history consisted of a father who had asthma. And then social history was only significant for having a new 10-day-old sibling at home, and the family was Spanish speaking. Next slide, please. With her physical exam, she was afebrile, respiratory rate of 50 with a heart rate of 188. She was noted to have a room air saturation of 74%, and again, blood pressures were not obtained. This patient was alert, moderate, with moderate respiratory distress. She had normal HENT, skin, and neuro exam. With her respiratory exam, she did have noted increased work of breathing with a rapid respiratory rate, abdominal breathing, and no retractions. Cardiovascularly, she was tachycardic with normal pulses, and her abdomen was soft and non-tender. Next slide, please. In the emergency department, because of her degree of respiratory distress and her low oxygen saturation, she was transitioned over to high flow nasal cannula up to 12 liters. Her oxygen saturation and work of breathing improved on high flow. However, she continued to be tachypnic to 180 while still being afebrile. This was her first episode of respiratory distress. Therefore, a chest x-ray was obtained. It showed hypoinflation, but some mild bronchial wall thickening, so it was loosely called bronchiolitis. She had a viral respiratory panel sent, and for those of you who are not familiar with that, that tests for the about 19-20 most common viral illnesses, and her COVID-19 was also negative. The patient was admitted to pediatrics for viral bronchiolitis, again with a negative respiratory panel. At the time of her admission, she was noted to have abdominal distension, so an APN lateral was obtained. Next slide, please. Here we can appreciate she doesn't really have a lot of lung pathology. She is hypoinflated, but we do note is quite a bit of air in the colon that they attributed to her high flow nasal cannula. Next slide, please. So within hospital day 1 and 2, it was really thought, I'm sorry, next slide, please. Thank you. Hospital day 1 and 2 was really thought to be related to respiratory distress. Her oxygen started to wean and she was eventually taken down to nasal cannula. She continued to have pretty significant abdominal pain and distension. And it was noted in further discussion with family that she had some abdominal pain and distension the day prior to admission as well. During her first couple of days of hospitalization, she became febrile. Her abdominal distension continued. Because of the air noted in the colon, small intestine, she had an NG placed, rectal tube placed to help decompress some of that air. On day 2, she developed an upper GI bleed where she had gastric output and stool that were guaiac positive. With the increasing abdominal distension, tachycardia, and appendix ultrasound was obtained. They were not able to visualize the appendix, but did note some free fluid. This time her labs were normal. She had a normal CBC, chemistry, but an elevated white count of 6.6. Next slide. On hospital day 3, she continued with her distended abdomen, but also noted to have orbital and extremity edema and became quite listless. At this time, CT of the abdomen and pelvis was obtained, and in more discussion with the family, we opted to do an MISC workup because, again, she was not fitting really at this point any kind of clinical picture, having come in with presumed respiratory failure secondary to bronchiolitis. She did eventually come out to be IgG antibody positive, and with further history from mom, mom had delivered a baby now 12 days ago, and mom had been told she was COVID positive at time of delivery, and that information was not obtained until day 3 of hospitalization. And then when you review her her previous pediatric emergency department visit, she actually had diarrhea and a couple of bouts of vomiting. So our suspicion is that was her clinical presentation for COVID 3 weeks prior. CT abdomen pelvis.
Hey, Anna, can I interrupt you just for a second? So when you're getting the ultrasound of the abdomen and the subsequent CT, I mean, her picture's all over the place. What were you guys really thinking about then?
So I took over care on day 3 of hospitalization. My sign out was a patient with respiratory failure, secondary to bronchiolitis with abdominal distension, and they were looking at possible appendicitis, which is why they got the abdominal CT. Again, they were really focusing on that abdominal distension, thinking it was related to the high flow nasal cannula. And, you know, for all the kids that we place on high flow nasal cannula, I've never seen this degree of abdominal distension. And it was not, you know, it was very apparent. The patient belly was firm, distended. She was a child who wasn't moving. So when I saw her, she actually looked like a child who had peritonitis. She was guarding, at which time we moved forward and got the CT abdomen and pelvis. So yes, it was all over, but our focus quickly became really, our focus became, you know, some kind of abdominal process going on. Next slide, please. So this is the CT, and again, we can see some bell wall edema, what was called a necrotic pancreatitis. And speaking with our GI, they really felt it did not represent necrotic pancreatitis, but more so an ischemic pancreas. And then the splenic vein thrombosis was also of concern. Next slide. She had a significant amount of ascites as well. I did want to point out her MISC labs as a trend, because I think it's important that we trend them, particularly when we're not clear on what's going on with our patients. At time of presentation on 3/20, she had our routine labs. I'm sorry, she was admitted on the 19th. On the 20th is when they expanded her labs to include a CBC, CRP, LFTs, and a chemistry. Her CBC, if you notice, her white count is not impressive. Again, she has that predominant neutrophil with very few lymphocytes. Her H&H was 13, I'm sorry, that should be 38. And her platelets, again, 262, so pretty normal platelets. CRP of 6.6, her albumin 2.6. And then she did have normal AST, ALT, normal chemistry, an anion gap of 6, and a blood gas. Blood gas was checked because of the rapid respiratory distress to make sure she didn't have a metabolic acidosis going on. And we see a very mild metabolic acidosis here. On the 31st, I'm sorry, on the 21st and 22nd, we see a mild bump in her white count. Her H&H has dropped. Her platelets, for the most part, are unchanged. Her CRP is mildly bumped up to, or has bumped up to 9.8, and her albumin continues to downtrend. Her, we did obtain a lipase at that time, which was 398. So the thought was she might have had a pancreatitis. We did have GI consult at this time. She was noted to have a mild coagulopathy. She received vitamin K. And on the 23rd, again, with those trends of labs, white count, mild bump, 13.1. Her H&H continues to downtrend, platelets non-impressive, her lipase downtrending. And this is a time that we started to look at the remainder of those MISC labs. So we do see all of those inflammatory markers bumping up. Her ferritin, her fibrinogen was normal. Her coagulopathy corrected. Her BNP was mildly elevated at 825. Remembering that in most MISC patients, we're going to see BNPs, in the thousands. And then her D-dimer was 7,650 with a normal high of 500. So next slide, please. The patient was admitted to our ICU. There she had consults that included infectious disease, cardiology, GI, ped surgery. She was started on IVIG, heparin for splenic thrombosis, high-dose aspirin, and she spent 8 days in our pediatric ICU. Her echocardiograms and EKGs were all within normal limits, and her follow-up as well. Right.
Wow, just wow. This is kind of an amazing kid in terms of the progression of disease, and also just how it, the presentation was bronchiolitis. I mean, it was pretty straightforward. Could you, I can't help but as someone from the ED standpoint, when I look at all these inflammatory labs, to me, it just shows how non-specific all of them are, because in some kids, one is really high, and in one kid, another one's real high. Any findings that you find more consistent with our kids?
Yes, I think tachycardia without explanation is one of the things that I've noticed in trends. Also hypotension. If you have a patient who comes in who is hypotensive, that should really start that thought process of MISC. We had a young lady who presented with a retropharyngeal abscess, was noted to be hypotensive at the outside facility, actually had a very large septic workup, including an LP, was transferred to another emergency department, still hypotensive. She was transferred upstairs. She was thought to have anaphylaxis because of a rash and hypotension. There was no COVID history at all, but when we did her antibody testing, she was positive. So again, those outliers, hypotension, tachycardia, just if it doesn't make sense, you got to think about MISC.
To my ED family, I live in the heart rate zone. Stay living in the heart rate zone with your patients. You've all heard me say it a million times.
Any other questions?
With the cardiac anomalies that some patients demonstrate. Is it just like symptomatic treatment, or is there anything specific for the cardiac anomalies?
So, again, with the Kawasaki presentation of MISC, our concern is going to be coronary artery aneurysms. We do know in the Kawasaki disease population, about 26% will present with that, with coronary artery aneurysms. Within MISC, it's just slightly over 50%. So we do know that there is a higher incidence of coronary artery aneurysms in the Kawasaki MISC population. Other things that we're seeing in relationship, we can see elevated troponins, elevated BNPs. Our echocardiograms are showing cardiac output that's decreased, a lot of first-degree heart blocks, cardiomyopathies, a ton of pericardial effusions, I think, that are related to the hypoalbuminemia. So, and again, that tachycardia. We really need to pay attention to that tachycardia.
Thank you.
Other questions, comments?
Wow, what a case. The one thing I think that I will mention, although this MISC seems to be more this post-inflammatory syndrome after COVID, is one thing I've also noticed in especially infants when they are have active disease, they tend to be more tachypnic than hypoxic, and unlike bronchiolitis, they tend not to have like increased work of breathing. It's just pure tachypnea. And I don't know if anyone else has noticed that, specifically infants that come in when we're worried about bronchiolitis. And I'm like, I don't know, they're just like breathing super fast. That those tend to be the COVID cases. Does anyone else notice anything like that?
I mean, I've certainly noticed that bronchiolitis is a tougher diagnosis to make this year. One, we just haven't seen as much RSV, but yeah, I mean, now that you mention it, I seem to be seeing kids who have more tachypnea than actual crackles and wheeze of bronchiolitis. They seem to just have the tachypnea. So I hadn't associated that with COVID specifically, but maybe so. Well, listen, I want to be respectful of everyone's time. Thank you so much for participating in this inaugural Child Ready Echo program. May